The first panel is going to focus on a program that you heard referenced in the video. It's a program in the Los Angeles area called e-consulting, or e-consults. I'm delighted to share with you that just in the last week they reached the milestone of over 50,000 e-consults performed for their patients. And this is going to tell us and inform us a lot about how to improve timeliness and cost of care. Our federal funds, of course, are all centered around the triple aim. One piece of that is cost. Of course, quality is another part of it, and satisfaction with care is the third part of the triple aim. My longtime friend and colleague, Lori Hack, is going to moderate this panel for you, and she's going to introduce the panelists. I'll be back when they're finished to introduce the next panel. So, okay, gang, let's rock this room. Let's give them a round of applause.
Okay, thank you, Pam. We'll try to rock the room. It's early. My name is Lori Hack. I'm with Object Health, and it's my pleasure today to be able to moderate this panel. In putting this session together, we really wanted to share some real-life experiences of how this version of health information exchange has been impacting lives in Los Angeles County. So what we thought we'd start with is hearing from really the godfather of e-consult, as we were talking about last night, Dr. Hal Yee, who is the Chief Medical Officer for the Los Angeles County Department of Health Services, originally came from Northern California to bring this concept in Northern California in its infancy, along with some other folks who've helped make this happen. We've seen over the course of the last year just a rapid expansion of the e-consult project in Los Angeles County under the guidance of LA Care Health Plan. We'll be hearing from Ralph Oyaga, who's not only an attorney, but a project manager and lead for the LA Care Health Plan's e-consult project. He's been working with a whole host of folks who have been out in the clinics to help implement e-consult and the whole concept that we'll hear more about from Dr. Lee. And then finally, what we'd like to do is just spend a few minutes hearing from Dr. Richard Seidman, who's the Chief Medical Officer of Northeast Valley Health Corporation. You might have seen him on the big screen earlier this morning. And he's going to share with you the real-life experience of how this technology can impact care in Los Angeles County for the underserved. And I think it's a really interesting story. So with that, I'm going to turn it over to Dr. Yee, if you can give us a little background of what e-consult actually is.
Hi, everyone. Good morning. When Pam was talking, I recognized with HIE it's Health Information Exchange. And it went through my mind that exchange can be used either as a noun or a verb. And I think there are a lot of folks out there. I don't actually know, Pam. Is that a noun or a verb in your usage?
I use it both.
Well, I think most folks out there think about exchange as the exchange. That's how I've heard of it. You read about the exchange. And what occurred to me sitting there is, as somebody in the movie said, you need that infrastructure, right? You need to have the noun exchange. But the real value for us is going to come when exchange is used as a verb. And the same is true for e-consult or e-referral, which is what we called in San Francisco. It became a verb as opposed to a noun or an application. And I think that's the key to HIE and all that we're doing in HIT. How do we turn the applications, the hardware, the software, these fiber optic cables into a verb instead of a noun? We're undergoing the greatest transformation in American healthcare in 50 years. And as we try to reform healthcare, we're seeking to provide high-quality, patient-centered, more cost-effective care. And this is kind of a new concept for most of American healthcare. But in the safety net, this has always been the case. We've always had to look at the clinical needs in a resource-limited environment. 8 years ago, I was recruited to UCSF to lead the GI and liver services at San Francisco General Hospital. Our wait times 8 years ago were 11 months long. People would come to clinic and we wouldn't know why they were there. They would come to clinic and they wouldn't have the right test done. So we would have to send them back out for more testing to return in a follow-up clinic visit, taking up somebody's space. Because I was just a scientist and not a hospital executive, not that there's anything wrong with hospital executives, I was too ignorant to know that you weren't supposed to mess around with the workflow. You're just supposed to extract efficiency. So it just dawned on me, even 8 years ago, that we had information technology, and in our system and throughout the safety net, we just have these wonderful mission-driven providers. How could we use health information technology to link these wonderful providers, to provide the expertise of expert specialists to our primary care providers? And so, working with a very small team, a guy named Kel Molvig, our IT manager, wrote the code for something that became first eConsult, then eReferral. It was very simple code that allowed the referring providers and the specialist to iteratively dialogue with each other in a web-based, secure manner linked to our electronic health record. In doing so, we tried to address the main contributors to the lack of access that we had in specialty care. So if you think about primary specialty care interaction across the United States, it's a problem whether you're in the safety net or you're not. Often, specialists don't know why the patient is there. The patients are often seen in the wrong specialty. People are seen by specialists when it's not essential for them to be seen. And I guess I've coined this the Goldilocks effect. Almost always the specialist sees the patient too early or too late. At least if you ask fellows. Fellows are constantly yelling at our primary care providers, why didn't you refer the person earlier? Why'd you wait so long? You know, it's, nobody can win. And so what we did was used IT to connect in an iterative way these individuals. And I think Ralph and Rich will tell you the upshot of it specifically, but in San Francisco, over the course of a couple years, it expanded and spread to all the specialties and many diagnostic studies, and really has transformed the nature of specialty care, and more importantly, the patient-centered medical neighborhood in San Francisco's safety net. It's brought a more effective, more efficient, but more importantly, a more team-based and patient-centered kind of care, driving down costs, improving effectiveness. And I did move to Los Angeles, but I will give credit to LA Care, which even before I came to Los Angeles, made an investment to help our safety net build and implement this system. We're very fortunate to have had vendors in Safety Net Connect who did a wonderful job taking the kind of simple rudimentary ideas that we had in our application in San Francisco and making them modern, making them usable for all of us in Los Angeles. So I will end there in my 5 minutes.
Okay, great, great. And so have you continued to be involved in this project then?
I reviewed 5 e-consults just yesterday. On my BlackBerry this morning, I got notification that I have an e-consult waiting for me. And as soon as I'm done here, I will go ahead and I'll help our primary care provider at Long Beach Comprehensive Health Center understand what they should do with their patient with GI or liver problems.
Great, thank you, Dr. Yee. Ralph, I think it might be helpful for the audience to understand a little bit about the scope. In the very beginning, sort of how small was it, and then where are we today?
So, as Hal mentioned, LA Care has been investing in health IT for quite some time. We had a number of projects before even our funding that supported the safety net providers in trying to get them to adopt a variety of health IT to enable them to be more efficient and so forth. And we were even putting out EHRs before the EHR incentive program was in place. So the history of LA Care supporting HIT is very long. So there was, in 2009, there was a pilot that was run with CenterMed testing out the concept of e-consult, and it proved successful. And over the course of the next couple of years, it expanded to include, we brought in, our lead at the time was Sajid Ahmed, who's in the audience. He's now the CIO for Martin Luther King Hospital. And he really spearheaded the effort to expand this platform. And Safety Net Connect really just took the platform to a new level. And we were able to bring in DHS, the Department of Health Services in LA County, to embrace the idea of e-consult and make it an integral part of their specialty care strategies. So we went from a very small pilot and to phase one, ended up with 107 sites that had implemented e-consult. So then we took the success, built on that success, and went into phase two over the last year, have gone from 107 sites to 188 sites. We're probably going to be over 190 by the end of the month. And as you mentioned, we've seen over 50,000 e-consults initiated in the platform. And that 50,000 e-consults, there's 4,000 users in the system, and about half of them, about 2,000, are PCPs. So I think from an LA Care's perspective, we really tie this to the triple aim. And so it's significant for us to see 2,000 PCPs using the system. Number one, we really believe that e-consult will improve the patient's the interaction with the system and the care that's being delivered to the individual. Number one, access, and we'll hear about how access has improved, but also the realization that specialty care doesn't have to wait, right? The PCP can access a specialist right away through an electronic consultation, and the patient is receiving specialty care immediately. They don't have to wait for the referral to go out. There's actually something happening immediately. And so the second thing is population, improving the health of populations. So I can envision this data that we're collecting now through eConsult, the providers being able to look at it and say, okay, now I've got this segment of my population that maybe I need some additional interventions. Maybe I need to look at and see, why do I have my patients that are being diagnosed with depression? I'm not really, there's the medication, the prescription for antidepressants is very, very low. Why is that? Is it because we're not really treating the patient correctly? So there's something missing. So the information, I think this is going to be the logical next step. Just as we're seeing with EHRs, the first phase of it is adoption, trying to get everybody to just capture the data. And the next stages are going to be, what do we do with that data? The CQMs are going to be more meaningful because now you've got something to look at. I think that's going to be the logical next step for eConsult as well. And of course, we all care about reducing the per capita cost of care. And I think that there's some things that you can really measure right away because you see the number of referrals that are going out, et cetera. But there's certain intangibles, certain things that aren't evident in the numbers, such as we're building the capacity of a primary care physician to provide care for specialties, for things that they are not really used to do. And so before the concept was, I can't really treat this, so I'm going to give you a piece of paper, hand it to you, and off you go. And it was a complete offload. So now we are giving the primary care physician the opportunity to ask a question of the specialist, not just once, but many times until they get it, right? And through that, I think that what we're going to see is a reduction of referrals because the PCPs, after seeing the same thing 3-4 times, they're going to know what to do next. So maybe there's going to be less e-consults, but that's not a bad thing, right?
And is that really your experience, Dr. Seidman?
Absolutely. So one of the things we do see, and I've had conversations with our staff physicians where they say exactly that. My director of pediatric medicine said she had an endocrine e-consult. She gave the specific clinical details. The endocrinologist helped her out with what to order. She got the test. They discussed the test results in this iterative dialogue that Dr. Yee explained. And she literally said to me, quote, next time I'll know what to do. So she won't send the same e-consult. She'll send another one, but she won't send that one a second time.
And so what are you finding then? This is one example of sort of the care improvements and keeping it within the primary care area, but what are some of the other things that you've experienced in you actually using the system?
So what we've seen in my health center, we have 14 sites in the northern part of Los Angeles County doing primary care. So as Dr. Nguyen was one of the other speakers in the video, she said that we don't have specialty care on site. So for us to access specialty care, it was traditionally that face-to-face referral. And in the context of health information exchange, we didn't, Hal and his colleagues up at UCSF and here in LA, when we started the pilot back at LA Care and the new project, we didn't say, hey, let's go build a health information exchange tool. We said, let's build a tool that will help bridge this gap between primary care and specialty care to meet a demanding clinical need. Ideally, we said, can we build a single common platform that community providers such as the community clinics in Los Angeles can use? We have two main types of patients, those with insurance, primarily managed care, and those without, or with the low-income health plan coverage through the County of Los Angeles. So we're a single provider. We don't want to use two systems. We wanted to use one system. So we were able to build with Safety Net Connects Health a single platform that would help facilitate these e-referrals or e-consults to disparate specialty networks. So what's interesting is the access to care was very different in those two settings. So the real driver on the county side, one of the key drivers was, as Hal said, long waits for access to specialty care. And you really refer and hope. And once a patient gets in, if they ever got in, you hoped that you'd also get some written information back from the specialty providers. Different scenario on the IPA side, better access more frequently. In the old school tradition, consultants actually dictate or type consultation notes that we'd get back in primary care to help advance the care of the patient. But even that would take weeks. Now, the average turnaround time in the system for specialists responding to primary care questions is 2 days. Honestly, the challenge is for someone like me, I have over 100 physicians in our health system. The challenge is getting my primary care docs to respond in an equally timely manner back to the specialist. So there's still this exchange between the primary care docs and specialists, and I loved your analogy about, there's never quite the right time. As a pediatrician, for me, it was always the peds ICU nurses, and with all due respect to any peds ICU nurses out there, you could never possibly transfer a patient to the ICU at the right time. It was always too soon or too late. This relationship between primary care docs and specialty, traditionally, neither group is terribly happy with the other. A pretty significant amount of dissatisfaction in the physician surveys that are done. This system dramatically improves that because we learn about what each of us need in our context. One of the big changes that has occurred, and Ralph alluded to this, is as more work is shifted to the primary care setting and we're able to defer these face-to-face visits with specialists, more work needs to be done in the primary care setting and more resources get consumed in the primary care setting, whether it's in the form of time or lab costs, imaging procedures, or medications. So the good thing is this is advancing and we are transforming the way we provide care. One of the challenges is payment reform hasn't quite caught up with the reality that it's now more costly for primary care organizations, at least on the front end, to care for patients as specialists help inform us of additional tests, meds, imaging to do, later referral into specialty systems, and more prepared, higher value visits, fewer wasted visits, as Hal said.
So I wanted to just elaborate on what Rich was saying in terms of this shift. That's such a critical piece of how this system needs to work and evolve, is there is a shift of work to the right person in the right location at the right time in the right means. And this kind of system has worked in the safety net pretty well because tends to be more of a managed care, less fee-for-service. So as we move forward with health reform and we have the other exchanges and ACOs and truly integrated health care, that will give us some of the financial tools necessary to cover those costs in primary care, which right now the FQHCs and the community clinics are challenged by. The other thing, though, that is subtle but a fundamental change in the interaction. For most primary care people, they're used to this idea of referring a patient for a specialty care visit, and they wait for an authorization or a rejection. At least on our side of the e-consult system, we've banished the word authorization or rejection. The whole focus is on providing care to the patient, providing advice to the primary care provider. Now imagine a system where we have a true neighborhood, where there's not a rejection, there's not an authorization, people are on the same team, there's no dumb questions, there's no good questions, there's only how we can help patients. And then you take that layer of authorization and all the paperwork and all the bureaucracy, and you take those resources and you vest it back in the patient-centered medical home in the neighborhood. That's how this is going to work, but it will be, this challenge that Rich said. We have to change how we finance this stuff.
And in terms of financing right now, is there compensation for the specialists for doing these consultations electronically?
In every system I've worked in, since we have salaried specialists and primary care providers, it just becomes part of their workflow.
So, and that's where the context is very different, since the platform supports both referrals into the county specialty system and referrals into IPA contracted specialists, mostly in private practice. So a very different answer. The IPA, my clinic is a member of, contracts with specialists and pays a fee-for-service rate for each e-consult that they do. It's at a much reduced rate than a face-to-face visit would be. So the IPA is still doing the math and doing the analysis to determine whether or not we can demonstrate a positive bottom line for their investment and what we're paying the specialists. If we defer enough face-to-face visits and pay that lower fee-for-service rate for the e-consult, the system will save us money. It's not only about the money, but we do need to pay private docs to do the e-consult. The early data, it's one snapshot. My clinic's been up for about a year now, but in the first 6 months, we looked at one specialty, and it's a good specialty, but Hal's got great data from San Francisco. They reduced the need for face-to-face visits significantly in many specialties, but just the snapshot of dermatology for my clinic, in the first 6 months, we demonstrated a 30% reduction in face-to-face visits. It's a very common need, both in adults and peds, and I just sent one the other day. It was fantastic. You know, this kid had something on the scalp that I didn't know for sure what it was. It had been there a while. It was growing. You know, I would have ordinarily sent that patient out to the dermatologist. Instead, I did my best to take a picture. It turned out to be a little blurry. The specialist was still able to interpret it, told me what they thought it was, attached a web link to an article that I could read with amazing photographs. I said, I'll be darned, I didn't realize this could look like that. So, you know, I learned something also, called the family, said, hey, the specialist is comfortable with this, it's something we can watch over time, we'll see you in 3 months at your next visit. So it was fantastic. So that was a cheaper interaction that happened in 2 days rather than weeks at a higher expense.
And we're looking at also, you know, so there's two models, the staff model, and then, you know, independent contractors within the IPA. But we're also taking a look at maybe creating some sort of network at the plan level that would cut across, you know, the IPAs as well, and you know how the financing of that is what we're trying to figure out as well. You know, is it part of the PMPM? You know, how would that work? So we're definitely thinking about it, trying to explore possibilities.
Since we have people from HHS here and other policymakers, I want to make an editorial comment that has nothing to do with my role for DHS. Please let us not turn this disruptive innovation into a fee-for-service product. We will not do well by continuing a fee-for-service, you know, turning this disruptive innovation into a fee-for-service.
And thus the reason for other thinking innovations around case rates and so forth. Excellent. I want to encourage folks from the audience, if you have questions, there are a couple of folks with microphones in the back here, so just raise your hand and someone will come to you. Since we are recording, if you could just wait for your question until you have a microphone, but go ahead and raise your hand. In the meantime, I just wanted to touch a little bit on the practical implementation of this. You know, often we hear technology is so easy, it's all in the cloud, you click on a thing here and the doctor learns how to do this all on their own. Maybe you can talk a little bit about how does this roll out, what does it take to get this up and running?
I'll defer to these guys, they're downstream.
Well, you know, what we have a team of people that support the platform at LA Care, but we also hire consultants that actually go on site and do the initial handholding. What we found is that you know, this isn't about just putting a product, an IT product at a site. It's really about workflow and understanding how to transform the practice of the physician's practice to integrate the specialty reviewer into the mix. And so we put a lot of resources into that upfront, you know, hand-holding per se, of, you know, understanding workflow and understanding how eConsult changes or fits into this new model.
It is all about workflow, and I was
annoyed at first when the trainers came in and they kept responding to our questions and comments to say, well, that's a workflow issue. That's a workflow issue. And it took me a while to understand that they were right. There was a lot about workflow that we needed to think about. And as Hal said, don't mess with my workflow. You know, efficiency is core to our business. Without throughput, we can't meet the demands of our patients. And the implementation and training it is time-consuming, costly, challenging. Any type of change management, and all the emotions that go along with that. In my organization, we had just implemented, we went live on our EHR in April of 2012. And that was we did that over a 6-month period of time. And right about that time, LA Care was knocking on the door to, Saj was knocking on our door to come and roll out eConsult. And not only my providers, but the entire staff was a bit change weary. And was it really the right time to introduce yet another health information technology? And sometimes you just got to accept the fact that there's no time like the current time. And why wait? Because people were in change mode. So we kept it going, and to have the advantage of right inside our EHR, you hit a tab, open eConsult right inside the EHR. So it's a simple toggle back and forth. And people even complain with the simplicity of that simple click back and forth between the EHR and the eConsult platform. Cut and paste. So you write your clinical background and history and question once, not twice. So yes, it's 2 platforms, and it does not yet interface. We started where we could, a single platform for dozens of clinics and more than 1,000 physicians on multiple EHRs. Doesn't matter, doesn't interface yet. And had we waited for that, you can ask the Safety Net Connect guys how much longer we'd be waiting to even start. So with some cut and pastes and a simple toggle, it is efficient, but took a lot of time and effort. And we rolled out, every clinic rolls out differently. But we certainly had the support, and then we embraced it and made it our own, and we're spread over 14 sites. And I think one of the key things that we learned having the county network and the private network is on the county side, Hal and his team were wise enough with their experience that they mandated its use from day one. This wasn't an option. We didn't say to the primary care docs, hey, if you'd like to try something new, different, time-consuming initially, you can try to use this platform. They said start from scratch. The IPA, again, the business case wasn't quite as clear. They didn't have the experience or the commitment to start day one. And if you're thinking, well, maybe adoption didn't happen quite as fast in the IPA, that's absolutely true. I had the benefit of some of the prior experience. And I figured, I thanked Hal behind the scenes. He doesn't know this, but I thanked him for doing the heavy lifting. It was mandatory in the county where many of our patients go, not yet mandatory on the IPA side, but I kind of left that detail out when we implemented at my health centers. So I like to be honest, but I just left that fact out. We just mandated it from the beginning, and ultimately our experience demonstrating our use, that helped convince the IPA to mandate it. And then from that day forward, the IPA's utilization just skyrocketed.
And that is a key point. You have to be committed all the way. Otherwise, if it's optional, it just doesn't happen. I mean, we have Object Health and E2O, our team that go out to implement this on site, and they'll tell you, it is a different experience when you don't have the commitment from the top down, so that people know we're coming in, we're putting this. The minute we turn this on, you got to use it. So it's crucial to have that. If you're going to do this, you got to be all in for it to be successful.
Question back here?
Hi, I'm Mary Wigg from Department of Public Health, Maternal, Child, and Adolescent Health. Have you used this with perinatology, high-risk pregnancies? And if so, what's been your experience?
So we are able to do e-consult between our women's health staff and the specialists in the county system. E-consult is not for urgent referrals. So if there's an urgent need, it's a phone call or how we've managed those traditionally. But for less urgent specialty needs, we're able to, our women's health staff are able to enter the clinical background history in question and get input from the specialty physicians. And sometimes resulting in a face-to-face visit, but if there's a question that can be answered outside of that face-to-face visit, it advances it, and as we've said, sometimes it doesn't ultimately defer the need for the face-to-face visit, but additional workup and management can occur along the way, and by the time the patient does get to the specialist, it's a higher value visit because both the patient and specialists are more prepared.
Another question in the back?
Hi, I'm Richard Pitts. Wow, powerful microphone. Must be the HIE effect. So I'm the CEO and CMO of Arrowhead Regional Medical Center, which is the safety net hospital in San Bernardino County. Question for Dr. Yee. Is this software package available for other public hospitals? Microphone died. At little or no cost? Can it be transferred? Free, I hope.
When I first developed it, I was a UCSF faculty member, and I looked into intellectual property and all of that. There's not really IP to be owned. So the concept is free. Now, the challenge, of course, is the code, writing the code, and the support of it. I will keep to generics for this question, but if you happen to be using a Siemens system, you can actually get the thing for free from San Francisco General. And there's at least one very good commercial vendor of this, but they will charge you because they're commercial. The hard part really is the doctor interaction. The application can be as sophisticated or unsophisticated as it needs to be. What you need is the exchange, the ability for people to contact each other, have iteration. There are a number of organizations, including Blue Shield of California Foundation, who is here today, who are interested in supporting porting e-consult or similar systems throughout the safety net. And I'm on the CAPH board. I think that we may be considering for the next 1115 waiver this sort of product or this sort of system.
So Richard, you'll be getting some phone calls later today for money. All right, great. Do we have time for one more question? Okay, a quick question.
I'm Steve Hansen. I'm an internist and a primary care person, and then a medical director. So as a primary care doc, you'll refer a patient for quality of care issues, for workflow issues, but also for liability coverage issues. And I noticed that Ralph's primary specialty is law. Has this changed the landscape in regard to liability issues in and around consultation and how we deal with things?
I don't think it's changed anything. I think it's a tool for coordination of care. And the interaction between the PCP and the specialists just happens quicker, right? But in terms of liability issues, nothing's changed. It's still the same whether you're consulting face-to-face through a phone or through a electronic browser. So.
And I'm not a lawyer, but I guess I'd offer my own opinion on it. Is honestly, I think we're better off because a significant portion of the time when we refer out in primary care, we don't get a note back, or there's a long delay before we get that note back. And now, whether it's days or longer, there's a written dialogue memorialized on the platform between the primary care doc and the specialty doc virtually 100% of the time. And if I read that and act upon it and document it in my record, I have it now. So we have more complete medical records with that primary care, specialty care dialogue memorialized.
Excellent, thank you. And please join me in thanking the panel. Good job, thank you, thank you.